a case of a 52-year-old gentleman with history of Heller's myotomy for achalasia about 5 years ago, and had a poem done about a year ago, and then now we're doing a surveillance. Dr. Kayla is doing the procedure right now, and Dr. Batista is right here as well, who's going to moderate the procedure, as well as Dr. Amy Tiber. Okay.
So this is a very exciting case. If you can show the endoscopy picture, please. Can we see the endoscopy? Yeah. So I want you to notice here the fundoplication. You see, it's a door. You know, it's a partial fundoplication, typically the one done after a Heller. And as you can see, this patient, you know, had on top of that a poem, and what we're going to try to demonstrate here is that the groove created by the poem is sustained. As you know, there is this very, you know, controversial data that achalasia patient might later on have cancer. So you have, if you start doing treatment of achalasia, you need to enroll them into a surveillance program. So as part of the surveillance program, in our institution, we do yearly based EGD associated with an OCT. So you've seen a lot of OCT during this conference. You've seen OCT in Barrett's patient to find the area of dysplasia and early cancer. You've seen OCT pre-poem by Dr. Batista right before done to confirm where are the vessels and avoid them, kind of a GPS technique. Now you're seeing a OCT post-poem to see how sustained are the myotomy in this patient. So here I am crossing with the probe into the stomach. Okay, and I'm going to start first by doing a scout scan here, right across the EG junction. You can see I can cross the junction very easily, even though there's a partial fundoplication. It's a little bit tortuous. It gives this impression of tortuosity. So let's do a scout exam here with the OCT. I'm at 15, Dr. Okay. Are they doing inflate here? I don't think it's... Yeah. Ah, it's inflate, yeah. Okay, good. I'm at 15. Okay.
I'm just making sure we're matching up the single line. That's the single line up there?
Yeah.
At 12 o'clock?
Yeah. Right there.
Yep.
This is a very easy procedure. We do it on a Mac. You know, you don't need anymore to intubate the patient, especially if they responded to the poem. Here I am across the E junction. So, as I said, it's a very interesting case because I'm expected to see a very short myotomy anteriorly due to Heller, and a much longer, what's that? Yeah, I'm going to come back a little bit here. And a much longer myotomy posteriorly. So we got to try to trace those images to see how sustainable are those myotomy.
I'm going to change microphone by camera. Where?
That's all that.
Here?
That was You can do another pull up and then do another scan.
Okay. I'll pull that one.
Okay. I'm going to do a full scan.
Yeah.
So what we're trying to look for is see that pinch right there. That's what we're going to look for on the scan.
late in the evening. So here we are doing a full scan. So I'm trying to center the balloon. That's the hardest thing, to get that position. And sometimes in those mega esophagus, it can be very, very challenging to do that.
That's better.
No, because he pulled out. Yeah, suction?
Suction.
No? I have to reposition it because it's helpful. So that position wasn't very good. We're going to deflate the balloon and I'm going to reposition across the easy junction. Let's aspirate the balloon.
Yes.
Yes, the esophagus is. As you can see, the esophagus is really, really large. Here, you see? It's really the true mega esophagus. And those, unfortunately, function as a, even though it's emptying, it functions as a reservoir for some food. And they tend, even though the patient is able to eat and gain weight, they function by overfilling. Basically, the big pouch gets filled and then it goes through the door. So even though they're gaining weight, they're eating, they have no dysphagia, they still have this bottleneck effect by the EG junction. And this is typical in those patients that have a mega esophagus. It's a little bit like the esophagus becomes a stomach itself and get to be overfilled to go through the EG junction, which, as you know, is not functional anymore and has a fundoplacation. So it's very interesting because functionally it's working, they gain weight, but there is a little bit of a delay and a little bit of stagnation of food that you can notice. So I'm going to try to close the EG junction again.
Question, Dr. Picala.
Yeah.
How often you screen them after they're doing well?
So typically what we do, we do a, I can start it in theory here. We can do a OCT postpone 3 to 4 weeks after, and then after that we do it on a yearly basis. Okay, can we start the scout now? Okay, let's see where we are with the scout. We're a little bit more centered now, as you can see, with a better position. And I'm going to ask Noel to orient the screen such as, you know, noon is noon and 6 p.m. is 6 p.m. And we use the black marker there as a reference point, which is around 1 p.m. So using that as a reference point, Noel is able to orient this in the same direction,
So we should be
the See, this is one sheet. She just put the marker at 1 p.m. And now we're going to look and see if there's any disruption in the musculature anteriorly and posteriorly. So you can see there is a disruption exactly at noon, which is probably the site of the surgeon is limited by the saphoid. And now I want you to watch the disruption posteriorly. You see, there is a persistent disruption posteriorly at 6 p.m., which is the site of the fluoroscopic myotomy. So let's go back down a little bit because now we are a little higher up. And higher up, we're dealing with this bottleneck effect of like dilated esophagus full of little debris. And I want, Noel, if you can just cursor, go down with the cursor to stop a little bit above the EG junction, a little bit above, and then show the disruption posteriorly of the musculature where it's disrupted.
Should be in this area.
Right, can you show that? Yeah, show that. Okay, here, you see how disrupted right there? You see, the musculature is disrupted. It's not a single line anymore. You know, you have to, behind the epithelium, which is continuous, there is a complete disruption of the muscular layer right there. So that is, we can maybe zoom in that area so we can show it to our readers. Okay, right there, you see that? How it's disrupted, and it's like, it's not continuous anymore. It's like a little blob. The blob is basically the fibrosis that comes at the level of the disruption to compensate for the loss of muscles. Because the body is not going to leave it intact like this. It's going to replace it by just a scar. And you can see it right there. Right there. Let's like this. Show, put your fingers right there. Yeah, right there is the area where the blob, which is basically conjunctive tissue, replacing the homogeneous layer of the musculature. And you can see that this is sustainable. This is a year and a half after the poem. And if you do it year by yearly follow-up, like we do it here, you can still see this disruption. So far we have data that goes all the way back to 5 to 6 years ago. It will be interesting to see if this persists after 10 years. Because this is exactly what we've been doing Paul for now 10 years. It will be interesting to see if indeed this groove is persistent. Okay, balloon down. Are we showing the endoscopy? No. Let's show the endoscopy now. Endoscopy. Okay, balloon down, please. Yeah. So this is a very interesting case because we were dealing with the fact that the patient was treated previously by Heller and reinforced the fact that POEM can be used as a salvation post-Heller. And I don't know what Dr. Batista thinks about this, but I think if there is one situation where POEM is probably the best therapy, and it's in those patients that failed Heller. What do you think, Alberto, about that?
Sorry, I was...
In the patient that has had already a previous Heller, if they fail the Heller, I think POEM is probably the best next step.
I think it's the only next step. That's the only situation where surgeons doesn't criticize that much the POEM. As a matter of fact, many of our patients that in which we are doing Heller after POEM after Heller are referred by surgeons because it's impossible for them, or it will be a very big surgery to go posterior for them. On the other hand, they will have to go to the thorax to access the thorax to keep going upwards with the Heller. So this is, I think, the only possible approach for these patients.
Yeah, I agree with Dr. Batista. There is a laparoscopic approach called a lateral anterior Heller, but it's not as efficient. because it's still anterior. You're still very close to the first area of the dissection. It's a risky procedure associated with complications such as more bleeding surgically and more perforation. I really think that the best treatment of a failed Heller is a posterior myotomy. This can be done, like Dr. Batista was saying, by thoracoscopy, by thoracotomy, or by a posterior POM. And I really think that nowadays, in institutions where POM is available, I think anybody who failed a Heller should be absolutely advised to have a posterior POM.
We have a question, Dr. Kayla.
Yes.
For the patients who failed endoscopic myotomy, how soon do you repeat or revise the, or try to do the opposite side? How safe? When it's safe to...
It is a very, very good question. The efficacy of a repeat POM on the other side, which means if you have a posterior POM, you go anterior. If you have an anterior POM, you go posterior. You want to do it typically after 8 weeks. You want to at least give 8 weeks between the two procedures so that you're not dealing anymore with any inflammation post-myotomy at the level of the previous resection. And in those patients also, if you're hesitating about how complete your myotomy is, I think there's also a place for OCT in those patients. OCT allows you to see the groove and can literally make sure that you are doing a myotomy on exactly the other side. Because oftentimes you come back, the clips are off, the anatomy of the esophagus has changed a little bit. You do not want to find yourself in a situation where you are cutting at the same area of the previous myotomy. You can end up in a very bad situation and you can actually have many complications. So you really want to stay away from any area that had a previous myotomy. That's a very important message.
The other question, how often do you see reflux after the POM and what do you offer them?
This is a great question. I believe that the real incidence of worsened reflux post-POM is around 15%. Some people give data reaching the 30% or the 35%, but I don't think this data is realistic. I think worsened reflux is around 15%. Some of those patients previously had reflux. We have to remember the incidence of reflux in the general population is anywhere between 20 to 30% all comers. So those are patients that probably had already reflux, then you do a POM, and then you find out about reflux. I think worsened POM as seen by persistent reflux symptoms post-POM, persistent pain, esophagitis, scarring post-POM. This is maximum 15%. We like to offer an all-in-one endoscopy solution. So we offer them a ESOFIX, which is transoral incisionless fundoplication. We have the largest series of those patients that underwent teeth post-POM transoral incisionless fundoplication. The efficacy rate is beyond 90%. If you select the patient appropriately, you have fantastic results. I'm getting signaled by my partners that we're going to move to room 2 for another case. So we're going to move there for the next exciting case. Hope to see you soon for another patient in room 1. Thank you.
So the next case will be with Dr. Tiber, which is about 57-year-old male with history of metastatic colon cancer. He came in. Hello everyone, welcome back. So we're gonna start with Dr. Tiber here too, about a gentleman who is 57-year-old male with history of metastatic colon cancer, metastatic to the liver with biliary obstruction. He presented with cholangitis, biliary obstruction, and had an ERCP with biliary stents placement. 2 days after the procedure, he developed fever, abdominal pain, and his CT scan showed perforation at the duodenum at the level of the stent, which likely from the end of the straight metal stent, straight plastic stent. We're starting an EGD now just to look at the site of the perforation, and we'll go from there on. We'll see what Dr. Tiber will do.
Hi guys. We're in just a second. You're going to see the endo view that I'm seeing right now, which is pretty impressive. You can see that here's the plastic stent that was put in. The ampulla is here on the left, and unfortunately the other end of the stent has come down a little bit and actually gone through the opposite wall of the duodenum. So you can see that instead of being just floating in the duodenal lumen, it's actually gone through the opposite wall. So the question is, how best to deal with a situation like this. And I think the first step is that we're going to need to remove the stent and then close the defect that it's caused. And the nice thing about these stents is they're pretty small. So this should be a very focal, small defect. But my inclination would be to actually close this just with the hemoclip, because I worry that if I were to take out the stent and come out and load an over-the-scope clip on it, I could actually move the site that it's the puncture site, because it's so small, it may be difficult to load there. So I've actually found that to protect that. I'm going to pull the stent now, and then I'm going to have endoscopic visualization so that I can make sure that I know exactly where I need to push once this is out. And again, just to emphasize, because this is an acute perforation of the duodenal wall, where I made sure before starting that we're using CO2 and not air, because this is a case where it's critical that we don't let any air escape into the peritoneum cavity, only minimal amount of CO2. And I started first with an upper scope. So once we close this, then we can use some fluoroscopy and see which stent this is and whether we need. Yeah, so we can. We're actually going to get a fluoroscopy shot now, just to know exactly which stent it is. And I'm just going to wait just a minute until we get a
Very focal area.
She doesn't have. I asked her. She just left them in the room behind the monitor. Yeah, somebody up here for me. So what you got doing?
Sometimes we like to do more just to make sure things are.
The actual Medtronic, the application. Who you bringing up? pretty straightforward at this point. But nobody in the middle wants to go out.
It looks good. So next we'll inject contrast through the scope into the small intestine and essentially do a version of an RGI series.
He's a little bit distended at baseline, but I don't feel a significant. Rafi, are you ready? Can you show the fluoro
There's the contrast going into the small intestine. Does not look like there's any evidence of a leak.
So it's whoever created the account. I mean, I can tell you it's 12 looking at this section, but it's not active. I can tell you right now it's not active. I know more than 12 people around right now. They come from the actual site, that link that they send out to register for. It comes from there. At the end, the way it's supposed to work, there's the first time I'm doing it. But from what I learned from the guy that sets them up in overseas, at the end of the whole
only
deal,
occurs in
they
patients
send
that
out a
don't
report
have
to
a
whoever opens up the account. This is how many people logged in on a computer. This is how many people logged in on a cell phone. They can actually tell if you logged in on a cell phone, if you logged in for whatever, what's the average number, what's the average time somebody was looking at the screen.
Alright, so that's going to be very good.
Yeah, you will probably don't get that. Like, I know I don't get it, but he'll probably get it. I believe it's somebody that he knows that set up the account. I just have to make it work.
It's incredibly rare. I mean, I think people see this maybe once or twice in their career.
Personally, I've only seen it once before.
Every patient that I've seen it or heard about it is somebody who has a cancer diagnosis. So I think there's something about the integrity of the work. Actually, when we replace the stuff, we may put a double picture.
Tyberg, another question. Would that change your practice to switch any malignant obstruction or any patient with malignancy to double pigtail? So just repeat the question, seeing these perforations, very rare, but in cancer patients, would that change your practice to use double pigtail with any cancer patient?
I think this is such a rare complication that it's not something that will change my practice. Certainly, I think in this patient, we feel like there's this travel wall is not 100%. In this case, my next step would be to get double pigtail instead of a straight plastic maybe run a little bit shorter. But I don't think that every cancer patient.
Thank you so much.
This patient in particular, what is the next beside the antibiotic and changing the stent to closing the
I think after we replace the stent, we're going to keep him NPO just for today to let everything
you're gonna get close. I'm controlling everything. I'm controlling everything. Okay.
Thank you so much. So we're going to start
Yep.
with the RCP now to
Yeah, you're gonna still stay in the room, but you don't have to worry about when they go live, or they'll tell me when they want to go live, and I can control it from here. I said it. I told you. I set this up yesterday, so I can control it here. You just gotta help them move things and then you can move things. Number 1 is the X on the floor. There's an X on the floor. So if you go to camera control and hit 1, the camera points right to where that X is. That's it. You just gotta help them switch to them. You don't have to worry about stopping and posting about it. Have fun. Learn something.
as you see here, the angula after this trial.
What are you setting up for? Yeah. Home? That's what I thought. You're not doing anything. You're not doing anything. Yeah, it's a pull. No, you're good, man. All of your guys are.
Big thank you to Kelly who just directed that wire perfectly into the right entry. I just sit here
It's a microphone and a camera. I can't get we don't have the right adapters for those, like those expensive AV mics. It's those 3 pins. And if I would have known, I would have bought them. It's those 3 pins for like a 3.5 inch jack.
The video is kind of shaky.
Yeah,
so it's a camera and a mic.
Yeah, so the camera and has a built-in mic. This is just like a battery pack. So it kind of suits the purpose, but it comes in real clear. So I was just like, you know what, go with that.
What's that going to be? Somebody up there call right away.
Just now?
Yeah, text that. Send me up there.
Oh, he wanted to leave. He had to go do something.
Ask him earlier. So where do you need to go? Don't sort of seem like now. You're somebody now.
No, he's
like a plan.
and I'm controlling everything from here now. So really, Minas was there just to switch the video. This is their room right now. These are the 2 cameras that I'm running here. This is my school standby, please wait kind of thing. And this is
Mina leave?
You're in the room. No, Mina's in the room. Yeah, he left.
How's it going?
No complaints. A lot easier than yesterday.
What do you do with the microphone? Are you able to shake?
Yeah, there's a. So we got the. Maybe I bought the expensive ones, like $600 mic. But they don't have phono-out jacks. They have those 3-pin real deal cables.
So
I need to like get that cable to go to a 3.5-inch photo.
What's the phone go to?
To the little box here.
Yeah, it's not a big camera. Big cable. And I tried to do it this morning. I didn't have the one. No, I think you have to make a cable. This morning. What were you required? I had another mic. I think what you use a different mic.
Yeah, I use a different mic. Because they needed the mic in the other room. They wanted 2 mics in that room. So the only option I had was the camera. Oh yeah, hey, pieces together now, one of them. You like the black diamond box and the non-black diamond roof? Right there in front of you, with the blinking light. Yeah, that one took some calling.
Yeah, I saw you put it up there when I had to go.
That took a couple phone calls. So like, yeah, we're not jumping if I need to do this. Originally, I had the camera here. That camera I had here, and I kicked it. So I'm going to refer to the box. No, it's fine. You got to do another case. Huh? You got to do another case. Yeah. I don't know. Honestly, I don't know. There's no, this room doesn't even have a thing anymore. Doesn't even have a schedule. The other room's got a schedule.
Why do you need not 2 people up here if you're doing
Because you can only control the camera. No, they were running 2 rooms at a time. No, yeah, he had cases. This place is fine.
No, I'm saying you're going to be broadcasting one.
No, I'm broadcasting them both.
Same time?
Same time.
How are you doing that?
I had to learn.
Because I see one video of that.
Right, you only see one feed, but there's 2 broadcasts. So when one goes live, the other one goes like on a queue. So when you're seeing the switches, it's because you don't see the turnovers. That's why. You're not seeing the turnovers.
I saw you're please stand by.
I had to go into something. I learned it. I'm online like, how do you add? Like I said, I learned this software. Come on, I learned it in one night.
So this video thing?
That's the video broadcast. And it's cool because it may take a good connection. I mean, it's a little.
We've been dropping out downstairs.
I had drop out in the morning. I had to make a couple phone calls. Everything kept dropping out on me. No, I get like a good first part of the morning. Every like 15, 20 minutes, I had to go live. Hey, Julie, have it? Let's take it live. Okay. Now I just learned how to control before I use my phone, the tablet. So now I learned that I can control the C's and I can move it over and it changes the view. See? So now I learned I can control that. So I learned to do it. These are actually pretty good, honestly. If I had a choice between the broadcaster or stand or something for that. There is. I actually made a stand at the one point. It's right here. I put this on your arm, and then this is actually the nut that turns on it. What I didn't know is that whenever the camera is here, the doctor's on this side. They're not working on the other side of the door. They don't work adjacent to the. It blinks out. Yep. That's why that's my problem with the microphone. That's okay. That's what my problem with the microphone was. Whenever the ESU was going off yesterday, the antennas pick up the RF. So I had to separate. Yeah. All you hear is the ESU going.
So you stay until the.
I say stay until it's done and then take the broadcasters off. So I have the boxes here. I'm gonna take the one of these. No, so I talked to Amy actually. Amy might still be here. I talked to Amy a little while ago, and after this, there is going to be a meeting to reevaluate our this is gonna, go forward. And they're like, yeah, no, there's definitely a meeting scheduled now. So this guy fucked this guy up too. This guy sucked up too. Don't get me wrong, he's been on occasion. He's been non-stop. This is the slowest. All right, but. In reality, yeah, sure. In reality, everybody European. In reality, you can, as long as you have everything set up,
Do you think it would be
you can
beneficial to
control
dial
it by
that
one
at all?
person. You can train the staff, have the X-ray tech when you like guidance system inside. And you have some person sit at a PC and just go live. In reality, you can have this room is different. Unless you put some kind of matrix in it.
Yeah, that one.
That room it should be no problem.
Miriam had two experiences.
They came up a little more. Actually, Mina came up and he was amazed. I'm like, now you know what the fuck I've been doing for like the last.
He was talking, both of them were talking, and they asked him any questions, and they had some questions. So he was telling them what he wanted. And they were very nice, comfortable with it.
Good.
So he asked no questions, he answered them.
No, the guys here, they're not bad. That's actually the stuff that he brought up here back in there. The guys that are doing surgery, the other guys,
Just a little bit.
My question is, how often is this going to happen? Once a month or so, What's up, man? How you doing? Good.
well, that's why I told Edgar before he left. I'm like, one, how long am I staying with this stay till the end? And then, two, what am I doing with the equipment after? Because the agreement with security was that we will. The agreement with security was that after yeah. Come on.
Inject the contrast now and see if there's any evidence of any externalization. It looks good to me. It doesn't look like there's any evidence of externalization. Excellent job. Next, we're going to have a little bit of a question-answer session before we go to our next case. The question was, why did you use a regular clip instead of an Ovesco over the scope clip to close that defect?
What I was worried about, one, is that sometimes the defect is incredibly small, and if you take the time to come out, load it over the scope clip on the scope and go back in, you may actually have a hard time finding the area again. It's also, it was a 7 French stent, and it was just a tiny, basically like a punctate hole, and I felt that it could be successfully closed with the lower clip.
That was the exact reason why straight stents were used in the last case. Is there any place for metal stents in this case?
So I think that this patient's ducts are actually pretty small in the intrahepatic segments, and so plastic stents are probably the more appropriate option in this patient.
The question is, should the patient now be on TBN?
I don't think it's necessary. You know, this was a really tiny hole, successfully closed with a clip. I think that we can keep the patient NPO for today, but I would be comfortable starting a clear diet as early as tomorrow.
It's such a small defect from that biliary stent. Some people would say pulling the stent just by itself, that area probably would close on its own. The question was, when would you revise these stents?
As long as possible. No, I'm just kidding. I think, you know, at least hopefully around 2 months at the moment, I would hope that those stents would stay.
Is there any issue with enteral feeding at this point?
Again, I think he'll be okay to start on a diet tomorrow because it's such a small defect and it was so successfully closed just with the clip.
We're now going to switch over to the case in the...
Good afternoon, everybody. Welcome back to the next case with Dr. Robles, Dr. Kahela,
and Dr. Batista. Dr. Robles, this should be a 10 minutes case. This is a 31-year-old female, previously healthy, does not take any medications, newly diagnosed with type 2 achalasia, and she's here for POEM. She never had Botox injection or dilation, so that's why I'm expecting 10 minutes procedure. We're gonna start with OCT, optical coherent tomography, to decide which approach we're gonna proceed with. Dr. Kahela?
are, so maybe we can do now a full run. I think I'm in a good position now. We do a full run. It's resetting. There is, I'm in a great position now. I pulled back about the level of when we're going to start the myotomy, and then here is a full scan. And then that's going to allow us to see where is the thickest muscular layer, but most importantly, where are the vessels? Is the balloon inflated correctly? Yes. It looks like it's a little bit on the weak side. What about now? Ah, that's better. Much better. Here we go.
Still in the sun. It's still. Okay.
Yes, there's cardio coming around.
We're still in the cardio. Now we're doing
Cardio
esophagus.
now. Oh, there's some nasty vessel. You see that at 5 p.m.?
5 p.m. as
You don't
you
wanna
see
go
here,
there.
there is a big vessel.
So based on that images, you can either go at noon or around 7 p.m.
I think it was oriented this way a little bit.
You adjust it now.
If you oriented now correctly,
So this is the muscles.
so you see there's still some vessel here.
So
At
as you
2
see, there is a
p.m.
huge muscle here, and
But those are vessels.
the white dots here are the glands, and
these are
the darker one usually the blood vessels.
like this.
So based on this,
What's that? That's-
See, he's learning.
you could go at 7 p.m. again, or around noon. Noon should be fine too. 7 p.m. or noon. So one more time, I'll remind everybody we're using the Olympus scope. The Olympus scope, the exit of the knife is more central than the Pentax. With Pentax, you really want to do posterior because the exit is more posterior. Here, you could go anterior, you could go posterior, but if you go posterior, you have to be beyond at 7 o'clock or beyond, not before. Otherwise, you will hit some of those vessels around 5 o'clock. Okay, so we're going to deflate the balloon. We're going to put a cap, and Dr. Robles is going to choose.
Okay.
You can have the cap. Here it is. Okay, Professor Robles, which approach you're going to choose?
We just put a cap, like transparent cap, over on the tip of the scope to help for the for the dissection and performing the tunnel. So the measure now around 40 centimeter from the incisor at the GE junction, and we're gonna go up to. You go 10 or 15?
10 is okay.
We're gonna go up to 10 centimeter above GE junction.
This is the pedal for water. This is the water of the
Yeah.
okay. And,
So-
I mean the water of the. We have
CO2?
no, the water of the.
Important to check your equipment before you start. So we're gonna start with US endoscopy needle for injection.
So we are here in our position to start our poem here. So we are at 30 centimeters. I think it's okay because the GI junction is at 40 centimeters, and we need to go a little bit 1 or 2 centimeters less than the GI junction. So we will have 12 centimeters here, and as already show us, it's better to start at 7 p.m. because first, because we don't have much vessels, and second, because we have the channel of this scope. This is a Olympus scope. It goes out from 7 o'clock. So I believe it's a better strategy to start there. Okay, you see? And how I can recognize I am in the good place, okay? I don't know if we can, this is the agent?
Yeah.
Okay. I will pass the agent first. Yes, first.
Okay.
Sorry.
Done. Keep, come closer. Here it is. I want you on that picture. Here you go. Because I don't see you. There we go. That's my team. Beautiful.
We need Alberto. Alberto is here or not?
Yeah. No. You look like a ninja, but that's okay.
I need to put spray coagulation here.
Spray coagulation. Just change the mode.
Oh, you want to do the, yeah. You can, to change the spray. 2
and 25.
25?
25, yes. And even 20. You can use 20. Because it's 30 days. This 20 will be okay. Because spray. Okay.
Okay. Great.
So we change a little bit the settings here.
No more this.
No more this. I need
Dr. Robles, can you comment just on the setting you just changed?
Yes. I like to use the spray coagulation here, but we need to reduce the numbers of the spray coagulation that is already set in the RB. I use the RB Vial 3. It's not available until now in the United States, but in the 300D you can use it. Okay, let's start here. Open. Okay. Put. Inject. So we are injecting here. Perfect. Go. You can go. You can inject very well. That will give you the possibility to work better. Okay. It's okay. Go out. And then you have the space here to start your incision. The incision you need to work with the cutting, pure cutting, and the cut effect 1. Yes, it's there. It's already there.
One length, 3 interval tunes. Okay for you?
Yeah.
And then look use eye.
This is a T type. Yes. Okay, fantastic. So I will use a Herbejet T type for my poem here. Okay, you can open now.
Sure. Hold on.
You are not connected?
Okay.
Now?
Yes.
So once you are inside, you can inject again. You see, the water will dissect for you. And then you can retire a little bit and you can start to cut. How much I will cut? Then space necessary to go inside. Okay? So with the practice, it's not necessary to do a big hole. It is very important in the initial incision to have a very good dissection of the submucosal .
try higher.
Okay, let's go. Now it's okay. So now I am using the Sprite coagulation, as you can see here. It's not a lot of watts, you see, very gentle. And the advantage to use the Sprite is that you will coagulate the vessels. We are with CO2. It's very important to do the point using CO2.
Yeah, CO2.
I will inject. You see that?
And now we're working with submucosa, as you see the muscle in the back.
Yeah.
And you still work at the level of the muscle, right?
Yeah. I am working just in my incision. You see, because you need to retire the whole. Submucosa. Okay, close. I will try to go inside now. This is the part, the most difficult time, but sometimes to go inside. No.
Wanna try with the knife close?
With the what?
With the knife close. Only the tip. If you close the knife here, you can coagulate that vessel easier, I think.
Close.
Works more like a plug. It's important that you can invest sometimes in doing a good entrance, a good mucosotomy, because if you want to go very fast, maybe you're gonna open more than you need. So it's better to take a time doing a very nice opening, a very nice entrance. So you be patient, like Dr. Robles is doing, just to have the smaller incision, the smallest as possible. Okay. If we can. Have you seen that report in endoscopy, Carlos, about doing a point with an ultra-thin endoscope?
With a what?
Ultra-thin endoscope.
Oh yeah, I saw that report from Dr. Conrado.
Use it like this. Yes. Okay. It's nicer, my friend.
Very nice. So we're getting through the tunnel.
Yes. Yes, now Dr. Robles is using the tip of the knife closed, which allows you for better control, a better concentration of the spray coagulation as well. As you can see, if you keep looking at the white tip of the knife, you're gonna have a better control of this, and maybe you can use a lower watt, a lower intensity of the current.
So now I am inside. Okay. I arrived to do a small cut. You can see here my submucosal tunnel. I am inside the tunnel. I like to work like Alberto using spray coagulation, but closing my tip, because you have more control of where you are working, and also you can work also close from the lens of the scope. So now I am very good now. So I will inject now. It's very important to inject. Okay, there is a vessel there, you see? Using a spray now. It's easier, you see. You don't need to change to a coagrasper. I am not saying that it's not necessary. Sometimes it's necessary to use coagrasper, but I really need to say that I am not using more coagrasper after I start to use the spray mode. You see, there is a vessel. You can continue working. It's very important to have a good dissection. You can advance also just pushing. This is a very nice case because my friend Dr. Cajale select a very good case for me. It's easier to work in this kind of patient. It's the difference from patient that has been manipulated with previous balloon dilation or other kind of technique. Moreover, if they use Botox, there is a very nice work from French people from Lyon that they show that Botox doesn't have any kind of results or good results in achalasia or other disorders. So it's not more justified to use this kind of treatment. And it was presented this DDW during the last DDW in Washington. So I am waiting for, okay, look, this is a big vessel, okay? Normally, if I saw this vessel, I will change to coagrasper, okay? But using spray coagulation, you will see how the vessel will disappear. You see?
Nice.
No more vessel.
Good job.
The other tip that when you are using spray coagulation is always go down, go in the muscle, work in this area and not in the not in the
mucosa side.
In the mucosa side because you will have you can have some necrotic areas after, so it's better to avoid that. So if you go to the muscle in that area, you will avoid this kind of problems. You can dissect. We are dissecting very well. I will advance.
This is the second rule. The first rule to work at the muscle side and avoid the mucosa. The second rule is to keep injecting, a lot of injection.
Yeah. Don't have fear to inject. I think the injection helps you to have a good dissection.
To dissect between
Yeah. So just keep going. We have very good submucosal space now.
And do you usually, like a question, we have a question about we see a lot of blood vessels in the tunnel, but not bleeding. Do you treat them like, prophylactic, or you leave them if they are not bleeding?
I don't understand the question.
So if there is a blood vessel, visible blood vessel at the side of the mucosa or at the side of the muscle, but non-bleeding,
Yeah.
do you start clogging them?
Sometimes it is a big vessel. Probably yes. Not in the mucosa. Sometimes it's necessary because when you pass with your cat, you can make bleed it. So it's not good if it is bleeding.
Right.
So it will depend on the size of this vessel. I am saw a lot of vessels here, but I am not doing coagulation of them. Not all.
Not all, right.
I am open a little bit more my tunnel. You see there is a vessel.
Right.
There is a big vessel in the other
There's
side.
one in the middle now.
You see?
Nice.
Okay, there is another big vessel down. You see?
Yeah.
Okay.
There's one
So
there.
I will use Sprite. And done. You see?
Nice.
It becomes white. No more irrigation. That's good. I will inject now. So I am in the middle of my tunnel. That's so good.
You're doing a very elegant dissection, Carlos. We can see you are working very close to your point, to the thing that you are treating. So it allows you a much better control, because we have seen some operators that work more distally. So it's a primary endpoint of your technique to get very close to the tissue always.
Yes, always. You will have more control. It's even like when you work in endoscopy. If you work too far, you will have less control. So it's better to work close. You will have more control. Like here, you see? And some rotations sometimes is necessary. You see, I am dissecting more to have more space to work.
The other thing that we have seen while you're working is that you cut and advance a little bit with a very soft, torquey movement of your tip of your scope,
Yes.
like you're doing right now.
Yes.
Just to adjust the tip of your scope in the field. Is it?
Yes, that's it. It's totally, it's very important to do that. Something that I didn't mention is that I learned poem with my mentor that was Michelle.
Yeah.
So I had the chance to come to New York to do my training, my first training, and then I bring him to have a very big marathon of poem, 15 cases in a weekend. So that was amazing. And now we are doing a lot of poem in my unit and a lot of benefits for the patients.
While we were doing the other case, there was a question for the audience asking about the balloon dilation tunnel construction technique. I'm very afraid of it. Have you ever seen that or done that? Or are you willing to do something like that?
I believe that this, there will be a lot of techniques. I think it's, if you are not looking inside the vessels, sometimes you can have some complication with the vessels. Even you will not find some vessels, and it could bleed a lot first. Second, that if you don't measure very well this dilation that you are doing, maybe you can have a mucosa leak, perforation of the mucosa if you don't have the right balloon or the good dilation. So I believe that I prefer to dissect. It will not take more time. This is not the issue of to go faster. This is an issue to have a good result, and I don't know if I can arrive to do the same doing the balloon. Maybe I am not so good, so that's the big problem. And,
oh, come on, you're very good, man.
And maybe there are people that are good doing that, but until now there are not the studies comparing both techniques. So I think we have more practice and more data with the dissection technique, the tunnel technique, using the dissection.
Yes,
so
I think unfortunately it has been abandoned. That idea of doing 1 second tunnel with a balloon, which is very dangerous. The tip of the balloon can go into the mediastinum and open a big hole into the mediastinum. So you have to stop the procedure and close it and go for another chance to do it.
So now we are very close from the GI junction now. We are 38 centimeters, and probably we will, in a few minutes, we will arrive to finish or
Dr. Robles, there is a question like, how do you tell you are at the G junction or you passed the G junction? What are the signs you see?
Okay, first, the measure. You need to be sure that your measure is good, and you need to measure the GI junction previously, as Michelle already does, and I already does. Second, you will see that the tunnel becomes closer, like the horizon in a beach,
Mm-hmm.
So there is a lot of this is a good sign. Third, the vessel becomes bigger, and then you will see a small curve doing that, and you will see that you are in the stomach side.
Very nice tunnel.
Yes, very nice and elegant conversation. This is curious. Sometimes you see a little fibrosis even in a patient that have never been treated, as you are seeing in the middle of your field there.
Yeah. But the fibrosis is due that now we are near from the GI junction, and you can find that many times, because when you pass the scope, you force. So it's the same. So there is a small area of fibrosis that could be observed in this kind of patient. But this patient is it's a not big fibrosis, so I believe there is a really initial disease.
I don't know if it's my impression, but the other thing that the other advantage with the sprite back, especially in this case that has never been treated before, is that you have less smoke. It's very clean. Yes, less smoke than with force wax.
Okay, now you can see that. So I would like to advance a little bit more. So I am 40 centimeters now. I am just in the GI junction now. I want to dissect a little bit more.
And how far you go down below G junction?
2 centimeters.
2 centimeters.
No more than that.
And the cut? This is the tunnel. What about the cut? Just the G junction, right?
I like it to cut at least 10 centimeters or 8 centimeters.
Okay.
Because there are some patients that have tertiary contractions. So that gives pain, and when you cut the fiber, it relieves the pain in this kind of patients. There's a small abstract presented during the DW talking about the full thickness resection versus just the circular layer, and to my opinion, in my experience, I don't see more pain in the patients or more complications. So what I see is I can go faster.
Carlos, now you're seeing a longitudinal muscle that is not the longitudinal, the other side, the inner layer. This is another sign that we are almost or over the GI junction. There is a fiber that is
there.
Yes, down.
No.
Down. Yes, at 6. Look at that fiber.
Yeah.
Yes, that's another sign that you're entering the stomach as well.
That is the big advantage that I see. You see?
Very nice.
So maybe it's time to see where we are. I will inject a lot, and we will go out from our tunnel.
Very nice tunnel.
Let's go to see.
And now you're looking for the bluish color, the methylene blue.
Yeah. Here it is. There it is. I believe we are here.
Yeah.
There it is. Yeah.
As you see here.
Wait. Okay.
At the cardia, at G junction.
Perfect. So now we can start. I will dissect a little bit more, and we will start to cut. Okay.
Nice. That's the other sign also to judge you are already there at the below G junction.
Where's my answer? Where's my answer? Steady. Yeah. I don't see my here. So now we are looking at my tunnel. My tunnel is going well now here.
That's very nice, clean.
Okay, I will dissect a little bit more, just a little bit more. So I will need some clips also from Boston Clips 360, please. There are some vessels from the stomach now, you see? And now they are coagulated.
Which neck you would like to cut?
Excuse me?
Which neck you need to cut? You use this one? Or
This one, the same one. There's the vessel from the stomach there. Okay, we are very good. We are ready to cut. So I will start my cut here.
And what are the options for the knife?
Can you open?
Yes. For the myotomy, use the same?
Oh, always the same, yeah.
Always the same.
So I will start my cut here. So I started to cut the fiber, you see? It's a full thickness now. You see, this is the longitudinal layer. Okay? Sometimes I use some spray behind because sometimes we can find some vessels down that we cannot see. You see?
Nice.
Vessel. So we have here sometimes doing some cases with Michelle at the beginning in Ecuador. Once we have a big bleeding, 1 hour of bleeding, because it was a vessel coming from inside the muscles. So it was very difficult to find the vessel. But now I try to perform a prophylaxis like this one, you see, using my spray coagulation. And I advance. But just at the end, so now so this is peritoneum done. Okay, I will cut here. I am just finishing.
Nice.
I will cut this fiber here. Peritoneum there. And let's cut. Very good. Excellent. Okay, we finish. I will put now wash please.
Can you use Gentlemax and wash?
Yeah. Yes.
Okay.
Please.
So
Oh, go.
And
Perfect. No bleeding.
and we used 40 to 80 mixed with 50 cc.
Good tunnel.
Very nice tunnel.
So
Clean.
now we need to close. I will see how is my mucosa. If there is, I am not,
It's widely open, the G junction.
So now, please give me some clips.
So probably we need 5-6 clips at least. Is there any approach like to place the clips?
Yeah, always to put the clip, at the tip of at the beginning of the incision, because this will the repair point for
Right.
you,
Nice.
and also it help you to put the other clips. Please open. So now I will rotate. That is one of the big advantage to use this clip, that you can rotate the clip.
It's a Dura clip. See, as Dr. Robles mentioned, the first clip at the edge, at the tip, the end of the
Close.
opening.
Close.
Very nice.
Close. Close.
Deploy.
Deploy. So now, maybe 4 clips will be okay.
This is like the advantage of the link for the smallest car in the beginning, right?
Yeah. You open?
We're placing the second clip now. Very nice. And the idea to get the both lips.
Okay, close.
Nice.
Okay, deploy.
Wonderful.
So now 2 more clips. I think should be fine. Okay, open please. So I can rotate by myself the clip. That's very nice. Okay, now close. Close. Okay. 2 clips. I think it's okay now.
Very nice.
No more than that. It's very close.
Looks perfect.
Looks very well. Oh no, it's okay.
You good?
Yeah. I'm sure that it's good. It's good. Perfect.
Looks perfect. So
Okay, we finish?
we're finished. So the procedure is terminated.
Fantastic.
Good job.
Fantastic.
So we're gonna start with the didactic sessions, and after that, if you.
Good afternoon, everybody. Welcome back to the second session for the day today. So the next case is a 68-year-old female with history, with extensive cardiac history, coronary artery disease, previous who basically presented with upper GI bleeding. She had an upper endoscopy and there was a lot of blood in the fundus as well as in the second part of the duodenum. There was mucosa formed there with bulky mucosa, and they questioned the presence of gastric or duodenal pharynx. So she will be here today for upper endoscopy for a second look to evaluate the sites of bleeding. and with possibly AUS to evaluate
Yeah,
the
but
possibility of the virus. The case will be by Dr. Shahid and Dr. Carlos Ramos, and we'll find out. Okay? Okay, Dr. Ramos, could you give us an idea about the current evidence for
Okay, there is a lot of data. Nowadays we have some one or two randomized studies
How many you need?
regarding the use of US comparing coils versus cyanocolate injection guided by US. And on the other hand, there is a lot of reports using US, just case reports around the world in many journals, using US as a very good alternative in cases of you didn't arrive to control the bleeding in some cases, even if there is arterial bleeding or vascular bleeding from venous bleeding. So I think it's very important to remember that the clinical aspects are the most important in this kind of patients. So at the beginning, the patient was sent to this unit as a cirrhotic patient, but clinically it doesn't appear. So we will see exactly, we will double check first to see if there is any other lesion that could be responsible of this bleeding, and probably it's not arise. Okay? I like to use the fluoroscopy because we're sending our first series using the angiography, because angiography is very important because you can arrive to the to determine if there is any kind of a shunt, for example, the triangle of the vessel, and any potential risk before to apply the cord or to apply the glue. This is very important. At least in our series, we had more than 90 cases now. Is that when we have some shunts, at that moment we will not put the glue, and we will use just coils. So that's very interesting. Yes.
And any size?
Okay, the size will depend from the size of the varices or the size from the vessel. Sometimes, if you have a very small vessel, I had some cases of type 2 gastric varices, and in those cases, sometimes it's not necessary to put the coil, just the cyanocolate injection, and it will depend of the diameter of the vessel.
Okay, perfect.
Let's go.
Find out. Okay, so we're going to start our case now by upper endoscopy to find out if there is any evidence of gastric varix or varix, and depends what we found, we'll proceed. Depends what we find, we'll proceed with possible endoscopy.
Australia, you want this over here? Live here? Live here now? Yeah, sure. They finished they're about to finish. I'll take it. What do you play with those students? What do you play with those students? Cookies?
So now we will perform an upper endoscopy, just an upper endoscopy to see exactly what. To perform a second look, just to see what is there was a bleeding from the dental bars. So we will check the esophagus. Clinically, this patient doesn't have any potential risk of cirrhosis, so probably we will not find
Last. Stomach is small.
They're just started scoping.
That's the enteral part.
Yeah, it looks clean too.
Just to complete the examination.
You want me to go audio here for you? And,
There's some erosions here and
okay.
got
it. What company you got? Oh, you got them over there. That's a good or a bad. That design half with this. Up to like the 180s. Best years in the. You work on it here? Yeah. I wanted to go to PA for to redo all the one stuff. The IE like fitting in the off because went to 3 years of medical school for that. You did? Yeah. And we came back. You guys should bring the breeding schools down. We do that a lot. Before we were in the market. One of the secondary camera and breeding crews. Where's the division? We're with the endotherapy division, so we provide us.
I think I think the clot is very important to be removed because you can find the lesion. You can find the lesion just near from the clot, so it's very important to remove it. We need to clean. It's very important to see what happened. There is evidence of bleeding, but
you see the ampulla here. You can see these signs. Bleeding, well, it's important to see the ampulla for bleeding in this pancreatitis, especially after severe procedure.
Let me know when you want to see that one.
It's a bluish.
That's the other one. What? It's a camera. Yeah, you can. You have audio issues. That's what you go to. That room's tricky. It's the file.
So probably this is the source of bleeding.
The setup is easy. The setup through almost occurs.
Red point or
especially things like this. Non-doctor video. This is not even what I do. I do telemetry and anesthesia. I can handle that. So they technically go down for 40 minutes.
This is the area.
The process in that room is actually about Pixar.
Beyond that area,
Pixar, you can actually design stuff out of video. And it's so only the technology to
Just the old blood.
now 2 years ago.
Don't see
Things like a new small division.
any
One process
evolutionary
is the access on the field. And you can do the system is actually a nuclear cell. It's actually from a nuclear cell. As soon as I said it, you have a cell. That doesn't work.
Okay, there are some few experience, not with varices, more with arterial aneurysm in this region. We need to think about why this patient have these kind of lesions. One of the possibilities is thrombosis after surgery, okay, that develops some vessels like this one. The other possibility is a arterial, small arterial vessels from the submucosa, but I am not so sure of the nature of these lesions. What do you think?
It's very difficult because if you look at the wall, it's circumferential. You see like in each part, multi-submucosal located vessel, and we don't know where is the target. But maybe with the ultrasound, endoscopic ultrasound, we could find the source.
Maybe. Let's go. Let's go to try. This is for the experts in enteroscopy. I think it's better for them. Where's the expert of enteroscopy?
Actually, we get colors, but I want it to be in the scope here too. Give me that palette. Give me the palette. What's happening on that? Let's see. No. Yeah, everything's cool. I mean, like, so it's, I think the possibility yeah, it's, I didn't set up so the way it works is, trust me, this is not my thing. I just had to learn it from what I remember. The way it works is, you use somebody else's platform. Think of it like Facebook or whatever media you can.
So we move to the next case, which is about a 61-year-old female with history of type 2 achalasia that was diagnosed 2008. She had previous balloon dilation twice, and she's here for...
I'm watching. Someone give me a thumbs up and then I'll just switch over.
The procedure will be done by Dr. Batista and Dr. Shake. We'll switch to
So we back to room 1 with another patient that has achalasia type 2. This patient was dilated one time. This is going to be pretty straightforward palm. As we discussed previously, we always do a scout OCT as a roadmap to make sure that indeed we can visualize all the vessels. And you can see here that one more time there's a network of vessels located between 3 to 5 p.m. So in this case, you can either do a posterior approach around 6 to 7 p.m. or you can do an anterior approach around 11 to 12. So I think Dr. Batista elected to go posterior, right, Alberto?
Yes, I plan to go posterior.
Okay, so one more time, this will allow hopefully to make this a very smooth and speedy procedure. We can go now to the endoscopy image to see the very
So we're back here. We have the endoscopic ultrasound scope in the duodenum, where we saw those areas that were oozing and bleeding. So it looks like the regions are vessels. We've confirmed that with that. We're currently measuring the size. As you can see on the screen, it's 4 millimeters across there.
This is the feeding vessel. This big vessel here is the feeding vessel. So I will use Doppler. I will use flow. You can see there is a lot of vessels in this area. I do not arrive to see any thrombosis from the portus splenic area, but probably is from the mesenteric. But this is vessel because this is a venous, because we use the Doppler here. As you can see, the flow is very yeah. So to my opinion, this is a venous vessel, and if I follow this vessel is the principal vessel giving the whole ramifications. You see, this is the most important vessel in this area, and it's probably who is doing the other ramifications. So now I will try to use a 19 gauge needle. It's not so easy in this position. Okay. So, and maybe this have more than one feeder vessel. We see another vessel down. I will show you. You see here. But probably is the same. Yeah, they are communicated. Yeah. So it's maybe I will try to attack here with this vessel, because in this area at your right it should be very difficult to go with my. This area is not possible to target with my US. Okay. So I will increase my.
Yeah, I think that's a good read, and then I left. So unless you look home at the end.
Maybe a combination therapy could be excellent for this patient, but I need first to go inside this vessel. Okay. So you see the position of my scope. It's not so easy. I will try to keep this position. I think it's always is better to find not the larger size. It's more the vessel that is given to these other vessels.
So right now we're loading the 19 gauge US needle through the linear echo endoscope.
I am using a slim flex needle, because it's very important to. You see, this is the proximal. This is the vessel that is bleeding in the mucosa. This one. I will show you by US. This one. You see? I will use e-flow. You see? Yes, it's communicating. Okay. So, but this is the vessel, the big vessel in the middle. The big vessel giving other areas. You see? So I think it's that is the feeder vessel, and now we need to try to target this area. So I will try to see my needle. I don't see.
So just to recap, we noticed these subepithelial lesions in the third portion of the duodenum. They appeared to be actively oozing and bleeding. We then proceeded with the EUS to locate the vessels and confirm that they were venous in origin and likely varices. We've loaded the 19 gauge needle and are now attempting to puncture the varices with the 19 gauge FNA needle.
So I need some saline solution just to flush. So I will try to go here. Okay. The position is not so easy. I need somebody to stay here. We are sure again. It's very important. So we are trying to target.
Once we get to the mouth, we will come back to you for a second.
So we've just punctured the vessel with the 19 gauge needle, and you can see on the ultrasound screen the needle is within the lumen of the vessel. We're now removing the stylet from the needle.
Wait, we need to confirm that we are inside. Wait, I need to perform aspiration. Here, what I do is to perform aspiration. If there is no blood, I am not inside the vessel. So I am just in the wall, at the beginning of the wall. So now, okay, now I pass. Maybe here. It's very important to be sure that you are inside.
Do you ever inject contrast under fluoroscopy to look to see if you're in a vessel?
Yes. I try to target the vessel. I am here, but I am not inside. It's coming. So now I am inside. Okay. So now I confirm that I am inside the vessel. Please. Okay, wait a minute. I need to flush.
So we aspirated blood, so we confirmed location within the vein. Now we're flushing saline.
Yes, can you give me one of it's hard. It's not good. Okay, let's go to clean the needle. Maybe then. Let's go to clean the needle outside. It's you need to pass the
So we just came out of the vessel because the saline was not able to be flushed. It's likely there's some blood clot within the needle, making it difficult to flush. So we're going to pass the stylet down to try to push out the blood clot and then try again. Prior to joining us, we did a preliminary EUS and we evaluated the celiac axis and the portal vein, and those vessels looked normal. There was no evidence of thrombosis. We weren't able to evaluate the SMV perfectly, and it's possible that there is thrombosis of the SMV that's causing these varices in the second and third portion of the duodenum.
Because the position of the scope is not so easy.
As you can see on fluoroscopy, the scope is in a very tortuous position, so it makes it extremely difficult to pass tools down the scope, and we're currently experiencing some difficulty getting the stylet back into the needle.
Again, it is difficult. The position is very difficult because the scope is very in a tortuous way. So the idea is to reach this area. I will show you again this area, and then to apply at least a coil or cyanocolate. I don't believe if the coil will be possible because the position of the needle and of the scope, but at least the glue, yes.
Do you worry about any adverse events doing the glue without the coil?
I believe that there is a thrombosis in the mesenteric vessel, so I don't know if at that moment we can have one kind, any type of embolization or something like that, but always is possible. The risk is less, but it's not impossible. We will perform an angiography. We will try to do that. It's very important.
So the needle was reintroduced into the scope, and now we're puncturing the barracks again.
Okay, I'm inside the vessel. I will perform aspiration. Nothing coming, you see? So we are not in a good place. It's not so easy. It's coming. I need to see the blood. Okay, now the blood is there.
So the vessel was repunctured, we aspirated and got blood return.
So now we are inside. Okay. We can try to push contrast. Please.
So the needle was flushed with saline and went easily now.
So you can see the angiography there. It is very important that the patient doesn't have any allergies. Okay. So I'm in a good position here. It's an important vessel. Can we flush with water, please? Just flush. Okay, now, I will will try to pass a coil inside. Yeah, the 10 millimeter is okay. We have the MRI 10 millimeters here. I'm not so sure because the position to push that will be very difficult. Let me see, it's 10 millimeters.
So we've done a kind of sort of a venography by injecting some contrast into the varix to confirm.
So we're sure regarding that. Silent this. Here, from here. I don't know how we pass because the difficulty here is to pass the angulation.
So the coil is now being loaded onto the needle. It will be difficult to pass the coil given the angulation of the scope. As you can see on fluoroscopy, once again we are quite twisted with our scope position.
And then once we are done, we can come back here. Wherever we are, we just take it from there.
So at this time I will change my treatment. I will use just glue because it's the position of this vessel is very difficult. So I will not arrive to pass my my coil. Give me one 22 gauge needle. So I will change the needle now. It's already manipulated this area, so I will try to perform just glue inside here. Just glue. Because the 19 gauge is in a very bad position. Now I don't have more space here. It's very small space because when you inject, you perform a inflammation of the endothelium inside of the vessel. So that's why you see like that. This will perform a compression for hours. Okay, so at that moment you can retake the patient in 48 hours to target again the vessel. But I will try to do with a 22 gauge needle because the vessel is we can arrive with a 22 gauge needle. It's easier to pass and it's just for injection. So that is my strategy now. Is to change. The coil was not easier to deploy because in this position is very difficult.
After initial glue or coiling, you said you repeat within 2 days. How often do you repeat this procedure thereafter?
Not normally. Normally is in the same procedure. So I will try to reach here. Give me that intensity. So we will flush with water. Retire the estimate. Please, can you retire the estimate?
Just past the 22 gauge needle now and have revisualized the varices and are puncturing once again.
Looks like you're in right now.
Let me see. Can we have some inspiration?
We're just aspirating now, just to check to make sure we're in the vessel. There is some blood coming back. We're going to be using cyanoacrylate glue. First, we're going to flush just to make sure. That's good. We get the cyanoacrylate. Normally, when you're injecting viruses, are you normally using both glue and the coils?
In this case, it's particular. It's the position. It's very difficult.
Took the servers off, so I want to find where the home
So there is this inoculate injection, you see, arriving in the whole vessels. Okay, fantastic. Great. I don't see no vessel.
Well, you have to look at it.
No more vessel. Salim?
Over the area one more time just to show. That whole area is now no longer flow. Excellent.
Anytime you want. Anytime you want. You let me know.
Excellent, John. We're going to switch back to room 1 now with the poem.
You want to talk? Yeah. Don't do it, Andrew, and talk. Don't yes. You're on now.
So we are back in room 1, finishing this tunnel. As you can see here, we just got at the entrance of the stomach. You can notice that the fibers are different. They're a little bit more smoother. It's a little bit tighter, you see. And then in the background, we just encounter many large vessels, which are typically the sentinel vessel that we encounter when we enter the stomach. So this is the stomach right in front of us. Just a few more, progression here, a few more millimeter maybe. And then we should be able to retroflex and see ourselves. This is the moment where you really don't want to have any injury, because you will have an injury at the level of the EG junction. Those are extremely difficult to clip. It's feasible, but we try to avoid as much as possible. So, you can see here, Dr. Battista very gently is injecting and dissecting and creating, the very last few centimeters of the tunnel. Surprisingly, the dilation has given a little bit more scarring than expected. Nothing compared to the Botox scarring that we can have. Nothing that could prevent us to advance. It was a pretty smooth progression, a little bit delayed by the dilation. But as I always say, if you want to temporize a poem, you dilate, you never inject Botox. What you can do with your Botox is give it to your nurse. Here we are, finishing up the tunnel, gently. Here it is. Here it is, very, very gentle. You see how Dr. Battista is staying very close to the muscle again, one more time. That is really the secret of doing those kind of therapy. It's very easy to get lost at this level. Very easy, especially when there's scarring. It can be torturous. You can very surprisingly find yourself on the other side. So you constantly pull back, check your position, check your angle, check your direction to make sure that you are going into the same and the right direction. That is really, really key. I've seen also very reckless endoscopists getting lost and finding themselves at this level in the peritoneum. So this is where one more time, where you really want to inject the more you can. I'm surprised by the intensity of the scarring induced by the dilation. But you can see that this scarring is different from the scarring of Botox. Yesterday, the Botox scarring, when Dr. Battista was doing the G-POM, was literally mixed with the muscularis. You see, the scarring induced by Botox doesn't just sit on the muscularis like in this case, but it just completely get embedded within the muscularis, which makes the dissection much harder and obligates you to actually cut some of the muscle fiber to be able to progress more proximal into the dissection, into the tunnel. So I think we're getting very close to being done with our tunnel. Here it is. Few vessels we need to coagulate. Very nice opening here. Yeah, we most probably now into the stomach. I think we can inject and maybe see if we can see ourselves in retroflexion. I think we are really, really close to be done with that tunnel. So we're going to leave the tunnel after pressure injecting the bottom of the tunnel. And then we're going to try to see if we can, you see the blue seem to be crossing. You see that? That's the blue. Here I think we crossed into the stomach. Here it is. Here. So at this stage, we should be able to